Call upon the next speaker, Dr. Jaya Krishna Reddy, Senior Consultant Orthopedic Surgeon in Yashoda Hospital. We request you to brief us on primary arthroplasty for trochanter fractures.
Good afternoon, one and all. Thanks to the organizing team and Dr. Bala, organizing secretary, to invite me here. The previous speakers, I don't think DHS is stated. I feel it's a gold standard still. When I go out of station or hometown and all, people, old people, afford, people who cannot afford, I still prefer DHS provided the bone stock is there. And PFN, it's good but expensive. Me working in a corporate hospital with a good number of patients, insurance and cash patients, I prefer doing PFN A2. And I feel there is a role for hemiarthroplasty in trochanter fractures, provided that we stick on to few basic rules of arthroplasty and we have clear indications. So, aging population is a problem. People, aged people, it's a burden, financially burden to take care of them when they especially have this kind of bad fractures. Because of the bone quality, bone stock, which is very poor, and we need to stabilize it and mobilize them as soon as possible to prevent other complications, bedridden complications. And we need not stick to all the Western publications, because our people, our bone quality and our combination all depends. Even 85-year-old Western person may have a good bone stock. We can prefer whatever the implant required at that time. But in our condition, probably say a 70-year-old person also, we have to think about the implant choice. I'm not going to talk about the stable fractures here, one part or two part. I'm going to talk only about the unstable fractures, where as previous speakers very well clearly explained about the lateral wall and comminuted greater trochanter and medial wall, free medial wall, which is clearly unstable case, and treating them fixation choices. We have DHS gold standard, and PFN A2 is also a gold standard nowadays, provided we get a proper indication for that. It has its own advantages, as previous speaker said. We can retain the natural hip, no blood loss, no chances of dislocation, and can resume normal activities. Whereas in unstable fracture, as said, posterior medial bone loss and severe combination, reverse oblique, shattered lateral wall, extension into subtrochanteric. Those are the cases where we have to really think about we have to do something else or go with the routine osteosynthesis. Internal fixation problems. Fixation failures happens because of the poor bone stock or bone quality, lack of previous medical management for the osteoporosis and post-operatively. We now, in these cases, we have to treat both the fracture and osteoporosis also, even the post-operatively. So, inherent fracture morphology, lateral wall blown out can, as said, we cannot get the stability there, and poor technique. People with inadequate experience can again lead to can give a bad results with routine implant fixations. If you don't respect the TAD distance and other things, other basic principles. And in these cases, we mostly go for delayed mobilization, which again further will complicate the post-operative long bedridden, all those things. So, as with the due respect to the previous speakers, I clearly say that all the fractures need not be treated with hemiarthroplasty. We can very well treat with PFN A2 or other surface fixators, provided the good bone quality stock and whatever the age it is, age is just a number. And few this kind of disasters we have seen in previously, recent past. As said, we have to have a proper selection of the patient. Indications were clearly explained by previous speakers. So if you don't have the proper selection of the patient for the proper implant, these are the disasters. And it's one-time surgery for this kind of elderly osteoporotic patients. So we have to plan accordingly. So this has to be salvaged, do a revision with hemiarthroplasty. Again, this is one more case where I explain reasons are clearly seen here. So primary arthroplasty for unstable extracapsular fractures in elderly, that's coxofemoral bypass. I feel it has there is a still road for that, provided again selection of the patient. There are very clearly, there was few papers are very clearly indicating pro for this hemiarthroplasty. There are recent past papers which are favoring the bipolar hemiarthroplasty, and these are the few more papers. So elderly patients around 80s, and we have to think at the time of surgery even about rehabilitation, early mobilization, and medical comorbidities, and definitive surgery. As said, only one choice we have for such kind of people. So they have potential problems in doing planning for arthroplasty here because of the osteoporosis, poor bone quality, and there is no proximal bone stock, because of which the landmarks are altered, and abductor mechanism is should be maintained properly, which because the combination of the bones is not easy to get it properly done. And fit of the stem is also important because proximally you cannot get a proper fit because of the combination, and distally bone may be very thin, cortex may be very thin. You have to use a proper implant, proper planning is required. So maintaining the length is important. So you can take the help of opposite leg, put it in the same position, and align the free fragments and plan accordingly. Probably you have to sink the stem little inside to get the abductor mechanism properly for suturing, and you can take advantage of modular implant. We can increase the modular heads though you sink it in, and you have to correct yourself with both lateral and vertical offset. So unstable arthroplasty in this group is a disaster and should be avoided. So maintaining the version, so you don't have the Trochanter here, probably you have to, your choice is distal femoral condyle and the shaft, where you have to take it as a consideration for the maintaining the version. I usually do the anterolateral approach, hard hinge approach, where I palpate, clearly can palpate the Trochanter area, even if it is fractured. According to that, I plan the version. So in such cases, bipolar hemiarthroplasty is done in most of the cases, cemented or uncemented. Mostly it is cemented. Uncemented, you want it to be very quick for some or other medical reasons. And meticulous abductor repair is very important. You can evacuate the patient very early in 1 or 2 days, as tolerated, and gradually with 6 weeks or 12 weeks, we can wean off them with the support, or with the support they can continue their walking. So in this kind of fracture pattern, the lateral wall, you can see the medial side, you can see it's comminuted. If you plan for the fixations, there are few complications with the poor bone quality and shattered bone. Unstable geometry where your neck is also fractured along with the trochanters. So such cases you have to use hemi with abductor fixation with the wires. Meticulous fixation with for the abductors is important. With the you can use the tension band wiring, or you can also use ethibond. If you don't fix it properly, there are chances of going for a dislocation like this. So abductor fixation is very important. You can go for cemented or uncemented. There are few calcar replacing implants also. I haven't never used that, but I've taken it from the others. These are few are Indian made and few are made by Zimmer and Smith and Nephew. Like the proximal humerus, you can fix the soft tissue to the holes in the calcar stem. 80-year-old lady, this hemiarthroplasty done, and 91-year-old lady, coxofemoral bypass, 86, and uncemented long stem. You all know this. There's one more case. Recent past, I revised this unstable kind of case. He's been walking. You can see the defect in the superior part. So I did not plan much, but luckily I could take the head and revise it. So post-operatively, you can weight bear them very well. That's the reason you are doing the procedure. Avoid abduction exercises. More dislocation chances because of abductor weakness. Prefer bipolar or dual mobility in case of THR. Arthroplasty is an acceptable option in carefully selected unstable fracture in elderly population. Arthroplasty in extracapsular fracture is technically demanding. Cemented calcar replacing or uncemmented distal fixation stems, proximal femoral bone loss, you have to choose. And early mobilization is the main thing. Hip arthroplasty in trauma scenario needs all the principles of joint replacement to get things properly done. And salvage arthroplasty is challenging, needing a experienced surgeon and aware of available options of a plan B also. So failure to plan is planning to fail is never more true in these scenarios. Thank you.